So Yanis. Okay, so welcome to this Boston scientific session. I think we are talking about the dream of the interventional cardiologist when treating left main disease. So what we want to have is a stent with a good radial strength, with more than 2 connectors in order to have something strong, with a good visibility, a low risk of longitudinal compression, and we know from Excel that it's double the risk of MACE at 3 years follow-up, optimal scaffolding and drug delivery, and easy side branch access. So maybe this is what you are dreaming for. And I have done a case yesterday morning. Okay. Maybe it's too short, sorry. And this is a result after using the Megatron stent. So during this session, we'll talk about the novel Megatron stent from Boston. You see, we have a very distinguished panelist for this session. And the program was a little bit modified because Adrian Benning was not able to make it. So we'll just present the characteristics of this stent, which is coming from the Synergy family, and then we'll have a case presented by Jens Lassen. Thank you very much. So while Yanis is presenting the stent,
yes.
I will show you, I will give you.
Okay. So while Thierry is dreaming,
And this is the Megatron. So you can compare and make your own opinion.
so I am not Jens. I think he's more beautiful than me.
Well, definitely not, but I can go change the...
So we need the slide. We need the slides of Dr. Yanis Chatzizisis.
Okay. I'll start counting to 10 and then I'll start talking without slides.
So Tom, you have to share with the other people in the room the stent, huh?
Okay. So, thank you, Thierry. Thank you, everybody. Guys, I'm trying to move forward, but doesn't listen. Help? No. Unresponsive. This thing doesn't listen. Yes. Okay, those are my disclosures. The outline, I'm going to very briefly introduce the Megatron and discuss the key geometry and mechanical properties of this stent. Then I will introduce the numerical modeling, testing of Megatron, and then some future directions. So, as Thierry mentioned, there are stent design dictates the stent mechanical properties. And there are several mechanical features that characterize a stent. Those 3 are really important: the radial strength, the axial strength or longitudinal strength, and overexpansion capability. Radial strength is determined by the number of peaks the more the peaks, the shorter the struts. The shorter the struts, obviously, the better radial strength, which is very important for a stent to be able to oppose the wall well. Also, strut thickness in part participates in contributing radial strength. So thicker struts always give us better radial strength. The number of links and the configuration of links dictate the axial strength. More links, stronger axially, longitudinally is the stent. And then the number of peaks also determines the overexpansion capability. So a stent that has more peaks is performing better when it overexpands. Left main is a different animal, and proximal main coronary arteries are different animals compared to mid or distal parts. And when it comes to left main intervention, we need a stent, or proximal AD, we need a stent that is very strong radially, very strong axially, and has good overexpansion capabilities. When it comes to mid-distal coronary stenting, we don't care much about axial and radial strength and overexpansion capability, but we do care about deliverability. So this Megatron is a sibling of Synergy, which is purpose-built for left main and proximal coronary artery interventions. So as I said, it comes from Synergy, which means that it shares the same core of platinum chromium, the same drug, and the abluminal bioresorbable coating, but also has some unique features that separates this, differentiates this from Synergy. First of all, it has 12 peaks in the circumference, which gives us very good radial strength. Second feature, it has more links, 4 in the first 2 struts, and then 3 thereafter, which provide good axial strength and resistance to longitudinal deformation, smashing of the stent from an imaging catheter or like a guide extension catheter or the guide. Third feature, it has improved visibility. Fourth feature, it has improved thicker struts in a way that they give better radial strength, but at the same time, those struts are not very thick to create issues with and exposing the stent to increase the risk for stent thrombosis and restenosis. So as you see here, the stent struts of the Megatron are overall quite thin. Fifth feature and sixth are related to the number of peaks. Increased number of peaks in the circumference give to the stent an improved overexpansion capability. A 3.5 stent can go up to 6.0 millimeters without deforming, losing the shape. And also it can have very uniform scaffolding, which is very important for the long-term outcomes. Here is a Megatron 3.5 by 16. You can appreciate here the overexpansion performance. That's a computational deployment. So the second line is the stent expanded at 3.5 nominal. And then the third line is the same stent expanded at 6.0. And you can appreciate the first 2 lines of struts have 4 links. Thereafter, 3 links. That's why there's a bigger gap between the struts after the third strut. Now, coming to the ongoing research that we do in my lab with this stent. As I just mentioned in the previous session, we have this computational simulation platform, the Optimize, which is important, helps us to optimize stent techniques. We discussed this in the previous session. I promised that it can help us to give you an example of how this can help us optimize stent design, and then also it can help us educate and train people. So here I'm going to focus. This Megatron thing is a very good example of how this computational approach can help us optimize the stent design. So the study is computational testing of a novel purpose-built everolimus eluting stent, the Megatron. The aim 1 of the study is that we compare 3 different designs of the Megatron. In the market right now is the 12 peak, but we also have the 9 and 10 peak. And we compare all those 3 designs in terms of how they perform in different patient-specific left main bifurcation anatomies, anatomical complexity of disease, and plaque materials. And then aim 2 is we investigate the effect of differential POT, more aggressive, more conservative, I'll explain, on the performance of Megatron. So that's the study design. We collect from our repository a good spectrum of bifurcation angles and disease complexity. We apply computationally provisional stenting using the Megatron, and POT, which is sized either 1:1 to left main MLD or more conservative 0.75 to left main MLD. So the 1:1 is more aggressive POT. We apply different material properties coming from the OCT, and we have a classification to cover the whole spectrum from lipid all the way to very calcified tissue. And then we perform computational stenting using endpoints, the fluid and solid mechanics, and also the stent morphometry. This is a workflow. As I showed in the previous session, we have processing of the angio and OCT to reconstruct the vessel, as shown here. We apply realistic plaque properties coming from the OCT. Then we mesh the wall. We use the range of the Megatron stents from 3.5 to 5.0, and we perform computational stenting. We take into account 4 major factors here, which are the key determinants of a stent expansion: the initial lumen stenosis, the stent design, which is fixed here, the plaque material, and the plaque thickness. And trying to see how those features, those characteristics, those determinants affect the expansion of the Megatron, we come up with this function, which is the function of the Megatron 3.5 by 16 expansion in relation to plaque type, plaque thickness, and the initial lumen area. And obviously, it's obvious here that the harder and thicker on the right-hand side the plaque is, the smaller the expansion of the stent. The softer and thinner the stent, the plaque is, the softer and thinner the plaque, the higher the expansion. That's obvious. But what is interesting here with this function is that we can predict pretty reliably, the R-square here is 0.98, the expansion that we're going to achieve with this stent if we know the plaque thickness, the initial lumen area, and the plaque material. And that's very important to predict how the stent is going to perform in different material properties and in different situations in the coronary arteries. So, coming back, this is an example. One, left main bifurcation. You see the LED disease extending to the left main. Blue is fibrocalcific material coming from OCT, from this particular patient. This data provided to me by Dr. Murasato, and I'm very grateful to him. And the proximal part has a fibrolipid plaque. Then you see the pre-dilatation with 3.526 computationally at 14 atmospheres. Then we deliver the stent, Megatron 3.5 over 28 at 14 atmospheres. And then POT at 5.0 proximally at 20 atmospheres. And you can see it here on magnification. You see the differential expansion, if it plays, of the proximal part of the stent, which at 5, it's a 3.5 stent, goes to 5.0 proximally without losing the architecture, the shape, and good scaffolding of the side branch. So on the left-hand side here, I provide over the length, between the dashed lines is the stented part of the artery. So on the vertical axis, the MLD, and with the green is the pre-stent MLD across the entire vessel. With purple, you see the expansion of the stent. The MLD changed up to 3.5 distal to the carina. Carina is this inflection point there. And then very proximally, you see the overexpansion of the Megatron compared to what we had initially and compared to the distal main vessel, compared to the LAD. And then at the bottom side, we have serial cross-sectioning of the stent from proximal on the left-hand side to distal on the right-hand side. Top row is pre-stent, bottom row is after stent. You can appreciate here very well expansion and scaffolding of the entire main vessel and distal main vessel compared to the pre. And that's some flow dynamics showing in steady flow here that the proximal part, which is overexpanded, has achieved good homogeneous flow environment there, flow domain. There is no flow disturbance in the also on the side branch. Carina looks beautiful. And then distal main vessel also has good flow, with the exception of this a little bit higher shear stress, the side of the very stenotic part, which was expanded with 3.5, but still it's fibrocalcific material, and it expanded to some degree. So future work here is to test this stent with 2 stent techniques, not only provisional and pot, head-to-head comparison to other second-generation DS. Maybe this is the opportunity to create now a purpose-built distal coronary segment, coronary tree stent, which is going to be mostly having better deliverability, but not much radial and axial strength. And then the big plan here is to go with a virtual clinical trial to show in a large spectrum of coronary bifurcations, human-specific bifurcations, how this stent performs. Again, the same group, a wonder group, and then special thanks to all those colleagues from around the globe and to my funding sources. Thank you.
Thank you very much, Yanis. I think we have very interesting information, and this is the beauty of EBC, combining science, engineering, technique. So thank you very much. Do you have some question from the room or for the panel? Yes, Dr. Pan.
My question is, if you need a second stent in left main, you put a Megatron covering the bifurcation, and you need a second stent, you would implant a second Megatron or a regular synergy? Because you don't need this property for scaffolding the
yeah. I think we're done with a big deal, which is the left main. The side branch it's like probably any DS can work there. Yeah.
So do we have any comment from the room people who were able to compare the two? Yes.
Just a short question: has the polymer integrity been tested also, apart from the geometry of the metallic stress?
Yeah, not in what I showed here. It's part of the game. It will be tested, but not today.
Mm-hmm. Okay, but you don't know results. Is the polymer integrity preserved after overexpansion?
I don't know.
Okay.
The data you showed were done without any inflation of balloon side branch, right?
No side branch inflation.
And the result was optimal as well, even if there's some strut in front of side branch. Is that right?
Yeah. So it's like pre-dilatation, stenting across the left main lady, and then pot proximally. No side branch dilatation.
Okay, thank you.
We have seen that in the particular case that you showed, there was some residual lesion at the ostium of the LED that could be improved by kissing ball inflation, or at least a dot that we should do in this case. But it was just, So
the purpose here was to show.
The objective was to show what are the properties of this stent, which is really a strong stent dedicated to left main or ostial lesions from the right or others difficult lesions on big vessels.
Yeah, I think this is really important question. If we have distal left main, or if we have to treat distal left main, so usually we have from the left main stenosis, we have a distal left main stenosis to treat, and this again, according to the literature, we have to use double stenting up to 40%. So this is if you written papers. So it means in around 30-40% you need to perform double stenting. And the question is really correct. Should we use Synergy or should we use again Megatron? And that's, I think, clinically this question will be important. But don't forget, if you stent from left main to LAD, and the plaque distribution in the left main is following. In 90%, plaques from left main are going direct to the LAD. That's why we usually stent left main to the LAD. The plaque is going in 60% direct from left main to the circ, but however, still in 60%. And if we have to consider this, that still ostial circ is our Achilles problem, you know, in left main bifurcation stenting. So I think we should use stent with good radial force.
Yanis, very short technical question. What kind of balloon was used for POT? What was the optimal position? Pressure, semi-compliant, non-compliant? Just a couple of words, because
can you call
projection towards the circ was mainly achieved by good position of the balloon.
So you helped me here. Thank you, Goran. So this is the pre-dilatation with 3.526 at compliant balloon at 14 atmospheres. So conventional pre-dilatation. This is the stent, 3.528 at 14, conventional expansion, well opposed in the distal LAD. There's still room to overexpand in the left main, and that's the post. We know that the transition point should be at the carina, a short NC balloon with very generous inflation at 5.0, 20 atmospheres. And the side branch is scaffolded very well here. So that's...
Why did you use 20 atmospheres in this specific case? Why did you use 20 atmospheres and before 14?
I'll do it at 14 as well. We can do whatever, right?
But I just know,
yes, we have a question here.
These Megatron properties of the stent are only in the proximal half, or there's a marker there, 1/3, 2/3. How do you decide which segment can go high pressure, which one you can leave for the normal size? I mean, there's any idea there of how many segments, how many struts, or just a rough guess? Or the whole stent is designed in Megatron way and can go up to 5.0 if needed?
Yeah, so what's the question?
The whole stent is designed in the Megatron design. The whole stent can expand to 5.0. It's only the proximal segment.
No, the whole stent can overexpand to 5.0.
Okay.
Yes.
My question is in relation to if you need to stent the side branch with the fact that there's a third link. You think that might be an issue expanding the circumflex stent?
Synergy has 4 links there, and it works well. Right? Synergy has 4 links.
Can you go more deeper in your question, because I do not understand your question?
Because we're saying it has 3 links in between the struts, so I'm just wondering if it could be an issue expanding the entry to the side branch.
No, this was tested in previous bench with Xion stent, and there is 3 connectors on with the Xion stent, and it's not an issue. It's even better because you have better scaffolding of the ostium of side branch when you open the strut. But with this stent, you have 3 connectors at this level and 4 at the proximal part. So you have really a high radial strength at this level for the ostium, and you need this because you know that there is a lot of recoil at the ostium of the left main.
Thierry, another important information is you can go with Megatron up to 6 millimeters, not 5, 6.
Yes.
True. Large number of patients of left main are high bleeding risk patients, and putting a synergy stent in left main, how much DAPT you recommend?
I guess what the guidelines dictate.
Guidelines, synergy has been tested for 1 to 3 months also. But in left main, you want to say something special about that particular stent?
I wouldn't feel comfortable with 3 months of DAPT in the left main.
But synergy has been tested against HBR For 3 months.
I don't think we can take the risk of left main thrombosis.
And we will discuss that tomorrow in the consensus session. So let's focus on this session.
So last question. Yes.
Actually, the previous Synergy had 5 connectors at the end. Now they've reduced the connectors to 4, although the body of the Synergy stent had 2 connectors, which they've increased to 3. But the proximal 2 cells of Synergy initially had 5 connectors for the large vessel. Here they have decreased it to 4. Any specific reason you've decreased the connectors at the end, although you want to increase the radial strength and the axial strength of the stent?
So the links, right? The links only affect the longitudinal, the axial strength. And based on bench testing, the design of 4 links in the proximal 2 struts and then 3 links thereafter gives adequate radial strength, longitudinal axial strength in this vessel, in this stent. The links have nothing to do with the radial strength. Okay?
So we have to move. Sorry, I'm sorry. We'll discuss after that. We have to move to the last lecture. So Jens will tell us what is the experience in the patient. Of course, you know that experience is very limited today, but seems to be very promising. So Jens, what is your opinion?
Yeah, thank you very much, and thank you very much to Boston Scientific to invite us to discuss this very, very interesting stent. I believe after my presentation we can continue the discussion of the mechanical properties, and I know that there are some of the engineers present in the session, and I guess they would like to answer some of the questions raised. What actually is important is what Thierry started out by telling. What do we really need for left main? We need a stent which has a capability of being large in one end and being not so large in the other end. And we don't have that until now. So let's see what happens when we use these in clinical practice. This is a 60-year-old male. He had a lot of concomitant disease, and especially a low ejection fraction and a low and very poor lung function. So he was not a candidate for CABG. He had some severe disease also on the right and the distal circ, but actually we went for PCI after a hard team discussion. I don't know if you could just click on the panel just to let the panel run again, so you maybe could have an idea of the lesion. Yeah, as you can see, it's an ostial LAD, and there is some disease further down the LAD. Sorry. We made an FFR, and it showed up that there was a pressure drop to 0.67 in the distal part of the LAD, and it increases up to 0.79 just below the takeoff of the LAD. So it's basically significant, but in the gray zone. Actually, anyway, we decided to continue to do the case. You will also see that there is some proximal enlargement of the LAD, and it's a bit difficult to predict precisely what it is. We started out with a plan of how would we treat this lesion, and we will treat it exactly the way we always do when we start with the provisional philosophy. Stent across the side branch, which in this case was the circumflex and the first obtusus marginal, or if you like, a small intermediate branch. Implant the stent with respect to the distal diameter, do the PUT, rewire, and do the KISS, and maybe do the final PUT. So these steps was actually intended, and these were especially intended in this situation because there was a very large proximal left main. So we would like to see how was the dilatation capacity and the technical properties actually of the Megatron stent. So this is actually just to show that it's possible to, well, increase the proximal part. And maybe in this stage we should just go on. And what we did was we treated the distal stenosis by a crossover stenting and a PUT, as we always do. There was no crossing, and the final result was nice. We carried on, of course, with with the stenting of the proximal part. Actually, we had 3 wires taking care of the intermediate. Please, would you make that run again? And this was after the initial stent implantation done with respect to the distal diameter, which meant that the proximal part was floating. So after that, we had the result, and we actually there we are. We did the pot, as you can see, non-compliant 5.0 balloon, placed exactly as we used to, and then we did a kiss. And after that, we had this, one back please. We have this this situation, and this is the stent boost. Well, anyway, you can hopefully appreciate that there's a huge enlargement in the proximal part of the stent. And maybe we could point to the fact that the connectors, there are 4 connectors in the 3 first crowns, which actually is really important when stenting the left main, because it's difficult not to engage the guiding catheter with a stent protrusion in the proximal part, which may cause some foreshortening and may cross part of the stent. Again, underlining the importance of finalizing with the pot. So, you will maybe also appreciate, if you take a firm look of the right panel, that it's a very straight tube. The stent was implanted with 10 atmospheres, so it's supposed to be 3.5. At that stage, it was a 3.5 20 Megatron. So it's actually fits the eye, and it fits what we were seeing in the angiogram. But we did an IVUS to see, because it was a bit puzzling that it was just a straight line. It could be floating. And if you appreciate the IVUS run, especially the left part, you'll see that it was not only floating, it was extremely floating, because there was quite an aneurysm. Look at this, and it becomes even worse. This is a 3.5 in the distal part of the LAD. So what to do? Well, test the dilatation capacity once again, find a bigger balloon, and do some more post-dilatation. Would you please click on the panel? Anyway, we did the post-dilatation, and after that we had this situation. So now it's nice in the distal part, but maybe too small according to the FINA law in the proximal part. So we found a 6.0 non-compliant balloon for the last pot, and actually we managed to dilate the proximal part of the stent to 6.4, which is, well, seen here after the next IVUS run, just showing that it was possible to dilate the distal part to 4.1, nicely opposed in the distal area or the proximal area of the LAD, but still plaque, but opposed. And then coming up to the left main, and the pot done there, and yet another kiss I didn't show, but anyway, we have a diameter in the ostial area of 6.4. So, coming to conclusion, this was after the final pot, and it's quite easy to see that there's a large left main part, and even not so small distal part as well. So this is the stent boost. In one angle, it's not the angle where you can see to the pot side, just to realize that the geometry in the stent was nice. And yeah, please go to this. This is actually the final result. You can see in the left panel the 6.4 diameter of the left main and the 4.1 of the LAD, and in the other projection you can see the nicely opened struts towards the circumflex and the small intermediate brands. So thank you very much for your attention.
Any question or comments in the room? the panel?
Yeah. We have now from Monday evening we have used a few Megatrons in our center in Bad Kreuznach. So even I could do a Tuesday and Wednesday double stenting in distal left main. So one was crush and one was tap. So especially in tap was really good to see I could cross with another shorter Megatron to the circ, and the crossing through struts was I was really surprised, very easy, despite the fact the stent is compared to Synergy a bit more bigger from profile.
Oh, but that's actually very interesting. But I wonder why you would use a Megatron for the cross, because I would like to have it in the large diameter. But if you cross it towards the circ, why use a Megatron? It doesn't really make sense.
Yeah, because of calcification, and there was a recoil, and that's why after kissing, it was needed to perform stenting.
Okay, yeah, well, but I think one of the beauties with this stent is that it is dedicated to take care of the proximal part of the left main mostly. So and I think one reason maybe for using it for other purposes is that if you go below the first 3 crowns and dilate, you will have an opening diameter of over 6.0 in towards the circumflex. But if you go up where you have the 4 connectors, it would be, I can't remember, 5 point something, I guess. So you have to actually be aware that this stent has a special design. It has more connectors in the top, it has more longitudinal compression resistance, and it has a better scaffolding, which makes it very good for the left main ostium. But I still would it just be better to use a Synergy for the cross in the DK cross?
It was interesting how this stent is performing in this situation. It was I was really surprised. Easy going.
Jens. Thank you. Thanks. In your clinical practice, how many left main need to go up to 5 millimeters? Because you can reach 5 millimeters with a conventional stent. So the main indication for this new design may be very big left main.
Yeah,
a proportion, a percentage.
Yeah. Well, actually, most of the stent can go up to 5, yes, but you have to crack them and you have to overdilate them. I know that I overdilated this Megatron as well because it's supposed to go to 5. But of course you're right. It's the very big that is an advantage, and not only the very big, but also whether you have a big discrepancy because between the distal diameter of the LAD or the circumflex and the ostial area of the LAD.
Yes. I just would like to enforce Mark's comment. I'm sure the Megatron was designed to do bifurcations and overexpansion capacity of the proximal segment, but it also has one of the highest radial strength based on the Synergy design, and so the circ is really an issue with recoil most of the time. Maybe that's a second indication where we can use it. Also, third indication would be proximal RCA ostium, where we have the issue of longitudinal compression with the guide catheter, and therefore the design is also more rigid, and that could be a third indication besides what it was intended for.
Well, actually, yeah, I acknowledge that comment, but still, you have to cross the proximal part of the stent, and there you have 4 connectors, which means you have to go through the area with double stent layer with 4 connectors. So the stent is definitely, in my opinion, not the optimal thing to do a mini cross before a DK cross. But of course, it could be debated.
Yeah, last question?
Yeah, just two small comments. I think in this large mismatch situation, it's better to have an idea about the ratio between LAD and left main diameter, so you can go with the appropriate balloon right away. And the other issue, my concern is about shortening when you are inflating with very large balloon this kind of stent.
Yeah, well, actually, but it was one of the things that was quite amazing. But I think the 13 peaks actually makes the foreshortening less. As maybe you could see it quite easily of the stent boost, because normally you will expect quite a lot foreshortening.
And you saw the simulation. So you saw the simulation, right? So with 6.0, the 3.5 to 6.0 did foreshorten, but not much. So it's essentially very minor. Very minor.
It's due to the design, which makes that it will shorten very little, even if you go from 3.5 to 6.
There is a big mismatch between the original diameter of the stent and the balloon are using. Shortening can be increased despite what is given by the manufacturing. So this is what I'm noting also in my case.
Yeah, what we should have in mind always is that in the majority of companies, the 3.5, the 4.0, and the 4.5 is exactly the same stent. So the only difference is the balloon. And the same for the 2.25, 2.5, and 3.0, the same stent, and the balloon is different. So when you use 3.0, you should know that you are using a stent which is the same as the 2.25. So I think it's very important to have that in mind, and Nicolas Foin have done this work, which I think you should have this figure in the CAS lab to understand what you are doing. I think it's very important, and the Megatron is different because it's 3.5, 4.0, 4.5 is the same, but the design of 3.5 is completely different as compared to another 3.5.
Yeah, and it could be different. I mean, if you are going off nominating pressure, nominal pressure, or very high pressure, that could make difference also as well.
Okay, so Coran, you want to conclude?
No. I just wanted to ask Nicolas Foin, I know he's somewhere in the room, if he can update and give us possibility to keep that scheme on Bifurcation website, bifurc.eu, so everybody can access at any time the most updated version for contemporary stents. So
and adding the Megatron in the figure, of course.
Because we need to have permission to do so, and we put it in the EBC website.
Okay, great. So thank you very much. I think we have to move to the next session. So the next session is the Abbott Symposium. Get clarity with OCT for left main on bifurcation treatment. So Adrian Banning should be here, but he was not able to come. So I will ask Tom Johnson and Dr. Cortese, but Dr. Cortese is not here. So I think we'll have a web connection to him. So let me introduce the session. So Tom, we are together. Thank you. So can we have the first slide, introduction slide? Yes, thank you. So get clarity with OCT for left main on bifurcation treatment. I think it's very important. And when you look at this evolution of images, you can understand that with OCT we can see better details. And this is very important. This is a summary of the Onuma paper, the joint consensus on the use of OCT in coronary bifurcation lesions that you can read in Eurointervention. I think this paper is really a must in this field, and we can learn a lot about the use of OCT in treatment of bifurcation lesion, left main, and so on. So we will learn that from cases. So Tom Johnson will show you a case, then we will discuss, and he will show you what he has done and what we have learned, and Dr. Cortese will do the same through the web connection. So let's start with Tom. Sorry.
Oh, can I take the pointers? It's going to make it even harder, I think, to keep this interactive. Thank you, Thierry, and thank you to the organisers for inviting me to give this presentation. So I was tasked with giving a case-based discussion on complex bifurcation. We just move forward one. So complex, we think Medina 111, we think complex two-stent bifurcation techniques. This is a bit of a cop-out on my behalf, but it led me to look at the definition of what we mean by complex, and the real-world definition of complex, there are certainly a couple we can draw out, which is many different or connected parts, so we can see that in the sense of a two-stent bifurcation, or perhaps for both patient and physician, strong or disproportionate anxiety, acomplex. So the patient I'm going to present for you is what we would term in the UK a frequent flyer, and he first presented at the age of 46 in 2004 with evidence of one vessel disease, and he had intervention to his left anterior descending artery with a cipher stent, proximally a taxus stent, slightly more distal. He came back 2 years later and required intervention to a very rapidly progressive element of disease in the right coronary, and at that time, due to the way in which we were funded, he received a bare metal stent to a larger 3.5 vessel. And then he continued to return. So 2007 he returns with atypical pain and has just an angiogram. He then within a year returns with an ST segment elevation infarct and requires then stenting of his left main stem with a 4024 Liberté, which is optimized just by a provisional approach to the circumflex. He comes back. I'm glad I've made this an interactive slide so that I can continue pressing rampantly, but 2009 he comes back, doesn't have any disease progression. I meet him for the first time in 2010, at which point there does appear to be some in-stent restenosis, but actually it does not appear flow limiting. 3 years later I take a slightly more academic approach to it and pressure wire it, and reassuringly at that point the disease is found to be FFR negative. But a colleague then 2 years later is persuaded by his symptoms to put a stent into the circumflex. So we now have stents in every single territory of this chap's coronary tree. And then the patient returns under my care again end of last year, just Christmas time, having certainly developed an increasing disease in the left anterior descending artery predominantly. So at that point, again, adopting a kind of thoughtful approach, take pressure wire to all vessels and demonstrate positive FFR in the LAD, but negative FFR in the other major territories. So at that point, I think we can say this is complex by virtue of many different parts and a disproportionate level of anxiety, certainly on my behalf, but I think also for this chap who originally presented at the age of 46. So I'll show you an angiogram. It's not that complex, but the situation is. So we see in a caudal and in a cranial projection, calcification plus stents and a bifurcation lesion in the LAD associated with a fairly large diagonal branch. So this is an interactive session, so I thought I would leave it just with the awareness of where the original stent, so we have a left main Liberté bare metal stent, followed by a cipher, followed by a taxus into the mid-LAD. Thierry, what to do now?
Yeah, thank you very much, Tom. I think the story of this patient is very interesting. The patient is really a nice guy because he came back to the same hospital for 10 years. And the only thing that changed is the name of the hospital. So you came from the Royal...
well observed, yeah, the Royal Infirmary.
Bristol Royal Hospital to Bristol Heart Institute.
We badged ourselves as a more specialist unit on patients who gain loyalty points for angiograms.
So some things against the Queen, or?
Yeah.
Maybe, okay. No, I think to come back to this, I think this patient, you have a significant lesion as confirmed by FFR, so you have to treat this lesion. And personally, I will do a provisional approach in this LAD, adding a stent with a provisional approach for the diagonal branch. But we can ask to the panel. We have a big panel in here, so who has any comment? Goran, you are part of the panel.
Simple protection, wire protection of diagonal and provisional with pot.
So you mean so keep it open strategy for the
yes.
diagonal branch?
Yes.
Yeah.
Can
Any other? Yeah.
He's done well with provisional before.
Yeah, it's true.
Yeah.
Other
Lima graft to LAD?
Graft to LAD.
Provisional approach to the LAD. It's not unreasonable. This chap has returned repeatedly.
Yeah.
Tom, how do you know where the lesion is? But, you know, the FFR.
So I haven't shown you the pullback of the FFR.
Yeah.
That's fair, but actually it was a fairly diffuse gradient back along the whole vessel, so there wasn't a significant jump. And I think angiographically, one of the things that is difficult is that there is some significant haziness intra-stent suggestive of restenosis. So I don't think it's just located at the bifurcation.
So Tom, did you add some significant drop between the two stents?
So as I say, it was actually a relatively diffuse gradient extending all the way back. There wasn't a significant step at any one point. I mean, so the stepwise sequence of this chap's history in some ways demonstrates my prevarication, my anxiety, which the reason for discussion at an MDT is I think surgery is a valid approach in a guy that has had repeated interventions. At the same time, we have to be mindful of the fact that he has actually done remarkably well, as you say, with a provisional approach to the left main. And in stenting this bit, joining the dots, we don't necessarily impact on him having a future operation. So that's sort of how the MDT discussion went. Maybe if we want to just add to the comment, I could show you the OCT, because that might then add some thought. So this is a preliminary OCT without having undertaken any predilatation, and I think is very instructive. And for me, stent failure is the one place where I can stand confidently and say I think imaging is absolutely mandated, because without understanding why a stent has failed in the very first place, we really have no idea how we're going to overcome the problems. But having undertaken this OCT, it becomes quite apparent he is complex. This is complex disease in a complex scenario, albeit the bifurcation is probably the least of our worries. So I don't know whether that changes your opinion, Thierry, but I can show you some stills. So this is a distal reference where actually Patrick earlier was saying that there's a difficulty sometimes with OCT about making a reference measurement, but actually at this point, which is just distal to the original stent, we get a nice EEM to EEM measurement, so we can see a distal reference of 3.4. So from a lumen, you'd be looking at a 3.0 stent that you'll upsize. But the most worrisome aspect to this for me was the really aggressive neoatherosclerosis, particularly in the taxa stent, where we see this very marked ring of calcium intra-stent with a significant, so the mode of failure, I think, in measuring this stent was that it was a significantly undersized, underexpanded stent in the mid-vessel of the LAD with an MLA of 1.9. And in fact, the diagonal bifurcation looks relatively free of disease. And upstream, we can't make comment on the adventitial element, the external elastic membrane, but the luminal contour of the proximal stented LAD segment is 3.5. So I don't know whether we want to comment or I can just show you what we did. It's probably most instructive. So there was some discussion earlier on about what do we do about calcification, and I think imaging with now multiple modalities for modification has led to quite an interesting idea of developing algorithms. And so actually in the first instance, I think ballooning and trying to modify the calcium is very reasonable. So took a fairly aggressive approach with a 3.0 non-compliant and then a 3.0 cutting balloon to high pressure, and then undertake another imaging run, because the importance here is to ensure that even though we see a balloon is expanded, to be confident that we have sufficiently prepared the vessel before contemplating another stent. And so here we actually see quite marked trauma. To a point now, with the last session, do we drug-eluting balloon this and walk away? You know, that was a comment that we've had earlier on. I'm not so confident, I have to say, but we see really marked trauma. And within that taxa stent, actually there is clear evidence of cracking of the calcium layers. The diagonal doesn't look quite so happy anymore, so I guess a show of hands, who's going to predilate this diagonal before contemplating a stent? Anyone predilate?
Will predilate? No predilatation?
No. people happy just to proceed?
Who is in favor of predilatation in the diagonal?
A smattering of hands.
And no predilatation in the diagonal. Okay.
So we've done the OCT, so actually we can look at the OCT. So I showed you the before looks great. The after looks a little bit more ugly. I have to say I took an approach to balloon. Now clearly there's a concern that you might injure. I think I could argue we've already injured. So I'm wanting this to be a provisional approach, but I'd want to maximise my chance of keeping that vessel open following stent deployment. And I think that's probably a controversial comment, but in this instance I elected to predilate.
So keep it open means that you put a wire in the side branch.
Yeah, I've just given a little squeeze with a balloon.
If you have a wire in the side branch, you will not lose the side branch.
No.
Even if it's occluded. Yeah, go on.
Would avoid. Yeah.
So it's a consequence. It was a consequence of predilatation and plaque redistribution, mainly, not the native lesion in diagonal.
And maybe some carina shifting.
And maybe
too,
some carina shifting.
Yeah, and I'm not presenting this case saying that I've done it right. I'm presenting the case with just the flow of thought that runs from the images. And I guess that's one of the dangers of imaging, is that we react to what we see. So here, this truly is reactionary. But having sized, as I showed you on the first OCT, I placed a 30x30 3-Zients distal to the original stent, but then crossing through the stent, being mindful of deploying it distal to the bifurcation. I don't want to leave overlapping stent across the diagonal. And then actually very usefully with stent vis, as we've seen in previous presentations, a very nice way of just accurately deploying the upstream stent with minimal overlap. And then undertaking, with the knowledge of the sizing from the original OCT, a 4.0 pop proximal onto the diagonal branch. And so then this is the next OCT run, and I've purposefully taken a run of how to then acquire the post-dilatation measurements and metrics. And here, because this is a meaningful bifurcation, we actually see on the luminal profile very good expansion from the pot in the proximal vessel. And then purposefully we've brought the assessment down to the level of the carina and beyond, and then making measurements of the proximal and distal half of that stented segment. And so we can then very, very rapidly, and this is real-time assessment, see that we have still some significant underexpansion with an MSA of 6.1, where at the top of the stented segment we have an area of 12. And then in the distal half, although we're getting close to reasonable expansion, 85%, we're at 4.9 with a reference of 5.9 distal. So this gives us quite clear understanding that there's probably some more work to be done in terms of post-dilatation. The other element to this is that having had the opportunity to post-dilate before doing the OCT, place the wire to ensure we can use the bifurcation software to check that I've gone for an appropriate cross. And we had some fantastic presentations earlier on. Yoshi and Numa showed us where we should be trying to place our wire. And certainly the 3D software gives us that confidence of knowing where we are. Although I must say here again is an area to debate is that we just have a small overhang of strut across the carina. Is this where we want to be, true distal or here? I elected to accept the result that we had, mindful of the fact that we would still be left with maybe some margin of stent overhang. But actually when you compare the pre and the post, I think we've got very nice opening of the bifurcation, but there may be comment related to that. And then having more aggressively post-dilated with a 3.0, 3.5 and 4 NC balloons, we can then compare the first run to the second run. So that's the one I've already shown you. And then the second run, if you just allow that to advance. Sorry, if you could just move forward for the slide for me. Oddly, we see this frustrating kind of flip-flop effect of the expansion. Sorry, if you could just press forwards on the slide for me. Okay, so I've managed to bring up the MSA from 4.9 to 5.3, so some benefit there. But oddly, the MSA, which was 6 point something in the proximal half, has now actually reduced following further expansion. And there is this tension then with how much do you instrument. The reality is that if you focus too hard on this, you could be there all day, ballooning after ballooning after ballooning. So actually from an angiographic perspective, it's reasonable. Although I'm drawn particularly to this area related to the second diagonal, which leads you then to go back and look at the OCT, and this would be interesting in terms of the discussions we've had about the bifurcation omics and the use of the data, because there isn't circumferential calcium here. There is a burden of calcific plaque and fairly heavy burden of disease that means that we're unable to fully expand the stent, but I'm not sure that we could necessarily have predicted this degree of underexpansion, 40% underexpansion in that area. And I'm not sure that rotablation or shockwave or any particular adjunct would have assisted us in overcoming that, but again, that might be a point for discussion. So the reality is that is my example of a complex bifurcation using imaging really from the start to the finish of the case, as Thierry has outlined as part of the consensus document that was published earlier this year. And so I'd summarize by just saying that stent failure for me is a place where imaging is mandated, and that's now represented with a 2A recommendation in the REVAS guidelines. Underexpansion, as we saw in this case for certainly that distal stent, does remain a very common driver, although from registry data we see that it is often multifactorial. The delineation of calcium is critical, and the fact that it will now guide us in terms of our decision making in terms of plaque modification, I think is going to be key to gaining long-term successes for patients. And clearly the technology, the three-dimensional reconstruction and real-time use of this allows us to optimize bifurcation. And beyond that now we have some fairly clear parameters for how to optimize using MSA 5.5 or 4.5. We're using the 5.0 as now a result of the ultimate data from the IVA studies, but aware of how we should be managing dissections and malapposition are all well outlined in the consensus document. Thanks for your attention.
Thank you very much, Tom. It was really a great case. I think one of the most important message is what you said about stent failure. So when you have stent failure, intracoronary imaging is very important to understand what was the mechanism of stent failure and how we can treat the problem. So thank you very much. So do we have comments or questions in the room? Or should we move to the next lecture? Okay, so we can move to Dr. Cortese from Italy. We're able to set up a connection to you. Hello.
Yes. Hello.
Thank you very much for being with us through the web. You can start.
It's a real pleasure. Just the web. I'm surfing on the web. I'm really disappointed I wasn't able to get there to you, but hopefully we will manage to have my presentation delivered. Okay, if you can hear me, I can try to share my laptop and my screen. So please let me know and interrupt me for anything. Can you see it?
Yes, we see the presentation, the PowerPoint. It's perfect. Okay. Go ahead.
So today, if we can start. This is the case of a 65-year-old lady. She was diabetic, hypertensive. She suffered obesity, and she had some stents placed in the LAD, the CIRC, and the RCA the previous 2 years. And then in January 2017, she was admitted for unstable angina at our hospital. And this is the left coronary system, which shows the disease in the ostium of the LAD and in the ostium of the CIRC. So what we did is that we did an FFR for the ostial LAD, which was positive, 0.78, and we judged positive also the ostium of the CIRC. So we plan to do a T-stenting. This is what we wanted to do. And this is what we did. We put a science 3.0 by 12 in the CIRC, and then we put a stentis, and the self-expandable stent 3.5 by 22 two stents in the left main, which was really strange. And then we have another run from the LAD. Here you can see the stent which is opposed in the LAD, but again, obviously in the left main, two stents, one here and the other one here, with some stenosis on the LAD. I show you the image again. That's it. And this is a still image of the OCT from the LAD and the left main. So I think that I'm done with the first part of the presentation. I think that now you can comment and suggest and whatever.
Yeah, thank you very much, Bernardo. I think it's a very interesting case. So maybe, Tom, you are an expert in OCT. What do you think?
I think it's a great case, Bernardo. The stent is, I mean, it's a clear indication of where imaging plays a role, and so you could be critical of having not undertaken this as an image-guided intervention in the very first place. I mean, having used stentis and moved away from using stentis, I think in the left main there were some advantages in the sense of how it might open into a side branch, but to do that without imaging I think is quite brave. And I guess that clustering of struts that you see so beautifully on the OCT is evidence of the fact that you have opened the stent, and obviously the stents are meant to break as part of their design, but has been left then with quite significant scaffold hanging within the left main, which clearly needs to be addressed.
Bernardo, can you show again the final result after the first procedure?
Or even,
and then the OCT images.
Yeah. And then maybe that final OCT image, because again, the most striking element for me of your final OCT is the very diffuse in-stent restenosis within the LAD that you're left with now. It's going to be a challenging procedure. So that MLA graphic in the middle of the screen shows very significant luminal compression throughout the whole length of the LAD.
So do we have comments in the room? Bernardo, can you show again the final result after the first procedure? I think it's very educative.
Yeah.
Not the OCT, but the previous. Yeah.
Yeah. This is the final
yeah.
assessment of the PCR.
So at the end of the procedure, the left main should be bigger than the LAD or the circ. So if we make some calculation, you immediately understand that there is something wrong. The left main is not big enough as compared to the fractal low. And the circ, also the stent in the circ looks not fully expanded. So I was not expecting this appearance at 6 months follow-up. Restenosis, yes, but not the mechanism of restenosis, which seems to be related to simultaneous. In fact, you create a T-stenting, but at the end it was a simultaneous kissing stent, in my opinion.
Yeah, that's it. Which wasn't possible because it was a 6 branch.
Yeah.
But that's the impression we get.
But again, it does come down to then using these novel type devices, and they're not going to behave in the same way as a standard second generation drug-eluting stent. So you will, by virtue of the design, fracture the linkers on the stentis, and how that then will impact on its strength, radial strength in such a large left main is questionable.
Yeah, we have a comment here. On here, yeah.
So the stent is a self-expandable stent.
Can you?
I'm not sure what imaging was done the first time. It would go to a certain diameter and it would stay there. You can't punch it unless you put a balloon expandable stent afterwards and stretch it.
The 335 will go to 7 millimeters in principle, but the crossing through the side of the device and ballooning will result in disconnection of the linkers.
Yes, but then there's another issue with the disconnection because, again, it's a nitinol stent. It doesn't necessarily flap over unless you put something that keeps it up there, scaffolds it.
Yes?
It's also my comment. So I think the self-expandable stent in the left main actually expanded further the next maybe 1 or 2 days, and then basically expanded over the circ stent that was tapped at the ostium, so it protruded over the stent, explaining that the circ struts are hanging inside the left main.
Remo?
My impression is that the first stent in the circ protruded 1 or 2 millimeter, okay? Then what happened? That the self-expanded stent was expanded in the main vessel, left main LAD, and the pot was done very proximal. Very proximal because they were afraid to go distal, so they did the pot very proximal. They opened the self-expandable stent just at the inlet of the circ, and so there was like a neocarina crossing because they opened the stent too proximally. Because you don't go with the wire distally, you have to go with the balloon to open the strut, and so they went, maybe the balloon slipped proximally and then opened the wrong strut.
Yeah. This is one of the limitations of the systematic T-stenting approach, which is not recommended by EBC. So starting by stenting the side branch will increase the difficulty. So I'm not sure about the positioning of the stent, too much proximal or too much distal. So it's better to put the stent after that, after main branch stenting. So now the question is how to solve this issue. Yes, we have a question here. A comment?
I also feel that the T-stenting was initially 1 or 2 struts had come in the left main, and when the other stent went from left main to LAD, that part of the stent never got crushed properly, because actually it was not a T, so sort of a mini crush, but that part of the stent struts into the left main could not be crushed because the pot balloon could never go distally. If it was a proper crush with a 4 millimeter or previous to before left main to LAD stenting, maybe we would not have had this picture. Maybe that area was never crushed, those stent struts. That is why we have those 2 layers, the distal left main.
Yes, other comments?
Another possibility could be while after doing this bifurcation, while pulling back the balloon, the side branch where we might have pulled back the stent in the left main, the side branch stent backward into left main at the index procedure, and that's why it's for hanging there. Because if it is a recross done and final kiss was done, I don't understand how come the stent moved back, unless while pulling back the balloon, the side branch, the stent was not fully expanded or fully opposed, and it migrated backward to the balloon itself in the left main. It was hanging there, and then the stent is keep growing outside it.
So, but the kissing balloon was done crossing proximal.
I think
this is the reason why there is this double lumen, because the balloon in the side branch in the circ went in the circ very proximal. As when you have, imagine the picture, when you cross proximally, okay, imagine the picture, you see that the main vessel, okay, you obstruct the main vessel. You have the same, so they cross proximally, and then they created this new carina with two double lumens across
I mean, the reality is that we're not going to be able to fully establish the mechanism, but this is a perfect demonstration of how complex 2-stent bifurcation techniques in the left main have a very significant hazard. And even in Excel, where we're hopeful that we have the most contemporary practice, it was up to a 30% kind of return rate with complex distal left main.
So one question, was DK crush done? They did the kissing before the self-expanded stent? No, this is the reason, because they didn't, so they went directly without doing
it was
the
not
DK.
The purpose was not to do a DK crush, but a T-stenting, a systematic T-stenting, using self-expandable.
But there was probably too much protrusion of the in the.
We probably ought to. Well, actually, what I have seen here, he did T-stenting with balloon, simultaneous balloon and left main to LAD. And then I don't believe that he protruded that much. What I have seen, it was not protruding at all that much in the circ stent in left main.
Look at this. Look at this. Wait, can you hear me?
Yeah.
Yes.
So this is the stent placement in a circ. It did not protrude at all.
Yeah.
In this case, I think that the operator put it a little bit further. We're getting close, but yet interpretation is different.
And another explanation is that you pulled the stent after deploying. Doing the case, you pulled, removing the balloon, you can pull the stent in the left main.
I think there is many explanation. Longitudinal compression can be also an explanation. But what is important is how you can solve this problem by using intracoronary imaging, because in fact, I think by intracoronary imaging, you understood that there was really a problem that you cannot solve easily, and the images can help you to solve this issue. So maybe you can continue and give us your explanation and what you have done.
Yes, I'm going to read. And that's the reason why we did the ROC1 study, which has been published very recently on CCI. We wanted to see if using the adjuvants of OCT as a distal left main adjuvants, we were able to assess the feasibility with the angiographic follow-up of PCI. This is the results that we obtained with the ROC1 study, showing that there was a trend toward a lower late lumen loss, and there was a significantly lower late lumen loss with the adjuvants of OCT for left main PCI in the distal part of the left main. And I'm going through very fast a ROC2 study, which has not been published yet, but presented this year during EuroPCR. This is a study with the clinical endpoints showing the adjuvants of intravascular imaging and OCT. We did 3 groups of distal left main PCI with DES, latest generation DES. All the patients should have had at least 12 months clinical follow-up. Primary endpoint of ROC2 is TLF. And we assumed in the 3 groups, number 1, that there was superiority of intravascular imaging versus angiographic guidance in terms of TLF. And number 2, non-inferiority of OCT versus IVUS, because this is what we want to show, that OCT is as similar as IVUS as a guidance for left main PCI. So this is the very big, very large, and very high quality group of physicians which participated to this study, 15 centers. So we put into our database retrospectively 730 patients, 377 had intravascular imaging guidance, 353 angiographic guidance. This was the first analysis. And a second analysis was a comparison between 215 IVUS and 162 OCT. Procedural results are a little bit different. Obviously, this is not a randomized clinical trial, but what is important is that intravascular imaging and most of the OCT was able, more than the other technique, to detect a stent under expansion, stent malapposition, and edge dissection. So the main result after a very, very long follow-up of almost 3 years, where the TLF was significantly reduced by intravascular imaging, 21.3% versus 10.8%. That was also reduced. This is probably a play of chance, and the other endpoints were not different. The secondary analysis, which is a comparison between OCT and IVUS, show a trend towards an improvement with this clinical endpoint with the OCT, 12% IVUS, 7.8 OCT, P was 0.10. There was a reduction in the death rate with the OCT, and the other endpoints were quite similar, with a trend toward lower TLR with the OCT. And we have, from this very day, thanks to CHEMA, the analysis of the propensity matching, which shows a significant reduction in the TLF in the first analysis, which is under-guided versus intravascular imaging guided. And again, no difference, but a trend towards an improvement with the OCT. So these are the limitations, but we don't care about this because we want to understand what happened to this case, to this lady. In our opinion, this is what happened. We put the first stent on the circ, and then we put the stentis. You are all aware that stentis has a specific delivery with a splittable sheet, which is broken upon inflation of the balloon. So in our opinion, what happened is that the balloon and the sheet, once were withdrawn, they captured the stent on the circ, which was not well expanded, and they retrieved it into the left main. So how we managed this case, it was very complex. We also evaluated if to send this patient to the surgeon, but we felt that the distal LAD was very tiny, so we preferred to try to manage it with interventional cardiology treatment. So we decided for a 3-step strategy, OCT-based, kissing balloon pre-dilatation with 2 non-compliant balloons, 3x20 on the left main towards the LAD and 315 on the circ. And then we did a non-compliant balloon port on 4.5x12 in order to crush the protruded struts in the left main. And then we used a final kissing balloon with drug-coated balloons, 3.5x20 in the LAD and 3x20 on the circ. This is the final result. It is not very beautiful from the angiographic point of view. The circ is not very well expanded. And this is the final assessment with the OCT, which still shows a not very well expanded stent and not a very well crushed stent in the circ. But that's what we were able to manage in this case, which shows a failure of the first PCI, which was not adjuvated by intravascular imaging. Patient after 1 year is still asymptomatic. She is still on depth, and she will probably will be treated with dual articular therapy for the rest of her life. And I'm done, and thank you for your attention.
Thank you very much, Bernardo. So do we have comments or questions in the room? I think there is possibly other mechanism of this problem, but very difficult to analyze. In this case, probably we'll have to do a guided optimization on what was done and maybe add another stent to treat, because at the end, in the last image that we have seen, there was no stent in the left main, just one part of the stent somewhere. Any comment in the room? Tom?
I think it's a beautiful demonstration of how imaging has given us a better insight to the mode of failure. And then, Bernardo, your data is very exciting in the sense of showing the impact that an image-guided approach can have on reducing event rates. I think what's striking from all of the existing data, so even in Excel, which we've touched upon, but image guidance wasn't mandated but was used to a certain degree, we see when we look at cases that have been image guided versus not, there always seems to be an advantage without even an obvious protocol for how we use
imaging. So just the badge of imaging seems to do something about giving us a better result. By using a mandated protocol, which I'd be intrigued to know how you've gone about doing that in the ROC studies, but by using a protocol for using imaging pre, during and after, then we can only get better results, I would hope.
What is very important in Excel is that we learned that longitudinal compression occurred in about 7% of cases, and it doubled the MACE rate. So I think we should be very careful with longitudinal compression, and that's why a good stent is very important, because of course the more radial strength you have, the less you have the possibility to have longitudinal compression. But of course you can have longitudinal compression with every stent. So the technique is very important to have that, and maybe longitudinal compression is also an explanation for your case. We have a comment in the back, yes?
Doing OCT for all my left main cases the last couple of years, and I think there are a couple of insights from that. First of all, every time you place a 4.5 millimeter stent in the left main, especially in a man, most likely it's going to be too small, because the median of left main is 4.75. So a 4.5 millimeter stent, you have to think every time you do that most likely it needs to be expanded. The other thing is that the proximal part of the left main is often very irregular, meaning that it's trumpeted, you will have some part of the stent that might not have stent deposition, where you need to expand even further to 5.5 and even 6 millimeters to get that part of the stent to get a stent deposition. And I continue to expand until I get stent deposition all along.
Okay, so I think it's time to...
Well, in this specific case, this was a lady which was...
Yeah, go ahead, Bernardo.
Which had a very 160 centimeter stall. So I think that the 4.5 was also because it was guided by the OCT was a good dimension. But however, I totally agree with you that the final result after the second PCI was not very acceptable. But that's what we managed to do.
Thank you very much, Bernardo, for sharing with us with this very interesting case. I think we'll move to the next session, and thank you again for being with us. So just before going to the next session, just to remind you that because of the trouble in the city, we have organized a dinner in the hotel at 8 o'clock. So be careful not to go in the center today. Thank you. Be a lot of very interesting cases, so stay with us because I think it will be very nice. Quarter to 6. Huh? Quarter to 6. Yeah, so it's now, no? It's now. So yeah. We need to sit. We start already. 5 minutes. Okay, so we'll start in 5 minutes. So you have time to take some coffee, and then we start this very nice session. 5 minutes.
Good afternoon. Hello. Welcome back after the coffee break. We're going to have a voting session now for one of the EBC case awards. First, second, and third. The Slido app is how you make your vote. So please use your telephones to go to www.slido.com. You can have Wi-Fi. It's Hesperia 10. It's enough to vote. I've been using it all day. Okay, so the Wi-Fi is Hesperia 10, Tower 10. I think it's in that order. Okay, and then you just go to Slido, put in the meeting code, which is EBC 2019, surprise, surprise, and then go to Auditorium, because that's where you are, and then choose Polls. Polls is the surveys and the questionnaires. Okay, I will open it up as soon as I'm off the stage. I will open it up and you will see each of the different case presentations and you can vote. 1 star up to 10 stars. At the end of the session, everyone has a chance to make sure they voted and we will give the prizes accordingly for the person who has got the best case presentation. Everyone clear? Okay, just one quick housekeeping. At the end of today, 8 o'clock, the session is due to finish. We have organized a welcome cocktail for everybody to be able to have some food and something to drink here in the hotel. It's going to be upstairs in the Jupiter room where the parallel session was. Okay, so just at the top of the stairs, go straight in. There's food and drink for everybody. If you're thinking of going into town, I won't say no, but please go to the cocktail first so that if you don't make it into town, you've had something to eat, you've had something to drink, and you won't be so disappointed. Okay? Thank you.
Good evening. Can you hear me? Okay, thanks for joining us. My name is Neus Albatella. I work in Barcelona. Thanks for staying with us. And I'm co-chairing this session with Remo Albiero and Yves Louvard on these very exciting 8 cases on bifurcation disease. 6 cases, yeah. And we also have a group of panelists who will discuss the cases, and you're all invited to participate. So the first speaker is here, Dr. Chan. His case is a left main bifurcation lesion. What did I do?
Good evening, ladies and gentlemen. I'm Dr. Chan from Tainan, Taiwan. It's my pleasure here to share you our experience. As an in-depth procedure, our patient was 49 years old with hypertension and hyperlipidemia. He has already received PCI twice for non-STEMI and unstable angina in the past year. This time he presented with crescendo angina for 1 month. The ECG shows sinus rhythm with a right bundle branch block. And there is no cardiomegaly in the chest X-ray. The echocardiography shows adequate LV performance with ejection fraction around 50%. In the angiography, we can see there are so many stents implanted in the LAD, first diagonal branch, second phase, as well as the OM1 branch. From these 2 projections, we can see the very critical stenosis at the ostium of the LAD and the first OM branch. And actually, there is also clinical stenosis as the ostium of circumference and moderate lesion at the distal lemma. As to the right coronary artery, there are also several stents implanted from the proximal along the vessel to the PL branch, but without in-stent restenosis. So for this lesion, we recommend cavity first, but this patient declined again as before. So this is the reason why we can see so many stents in his coronary artery today. So our target lesion consists of the distal lemma lesion and the ostium of the LAD OM1 branch and the circumference. There are 4 vessels and 3 ostium to be treated. Because his heart function is normal, so we don't think a left ventricular assistance device is needed. To the debulking plan modification, because there is no severe calcification seen in the angiography, we don't think it is not needed in the beginning. But in case need, we will use a scoring balloon, cutting balloon, or the rotor ablation atherectomy. And we think the intravascular image is mandatory for this lesion. And we chose IVAS rather than OCT because we think much amount contrast median should be needed for this to characterize this complex lesion. As to the stent strategy, we made a careful reassessment of the target lesion. As you may appreciate, the lesion at the proximal ostium of the LAD is considered majorly of in-segment stenosis and some in-stent restenosis. And the ostium of the first OM branch consists of in-stent majorly in-segment restenosis, and the distal lemma and the ostium of the circumference is due to plaque progression. So for this complex lesion, we don't think one stent strategy is feasible, so we decide to use a 2-stent strategy. This is our lesion. It looks like a Medina 1111 lesion. We intentionally divided into bifurcation lesion. The upper one is the Medina 111, the lower one is Medina 101 or 110. And we decide to use a cross technique for the upper one bifurcation and the provisional one stent for the lower one. And this is our treatment goal. We use a 7-French guiding catheter and we wire the 3 vessels and we predilate the LAD using the 1.5 millimeter balloon for IVAS. The lumen diameter in the lemma body is around 4.0 millimeter, and the stent expansion is good at the proximal LAD, but there are much instant neo-intima hyperplasia. In the subsequent procedure, we further dilate the LAD using a 2.0 balloon to diminish the blood flow compromise during the subsequent procedure. And then we predilate the ostium of the circumference using a relevant balloon, and we decide to choose a 3.5 by 24 millimeter stent according to the IVAS result for the lemma and OM1 first. At the same time of the stent inflation, we inflate a 1.5 balloon at LAD as a gel balloon to protect the LAD. This is the immediate result after the stent implantation. We can see the ostium of the LAD and the proximal part of the circumference become narrowing, which is due to plaque and carina shifting. And then we should rewire the LAD and circumference. Because the stent is just 3.5 millimeter in diameter, so there should be some space between the stent and the vessel wall. So we use a double lumen catheter to facilitate the wiring of the LAD and circumference to prevent wire going outside of the stent. As you may appreciate, when we during rewire the LAD, there are 2 stents seen from left band to the LAD. The yellow one is the second one, which is inside the stent, and the red one is the initial one, which is outside of the stent. After successful wiring, we perform a gentle kissing balloon technique for these 2 bifurcation lesions just to open the stent strut. And then we implant the second stent from the main to the LAD, and then we rewire the side branch using the same technique. And then we perform final kissing balloon for the LAD and the OM1 bifurcation first, which non-compressed balloon with minimal overlapping to avoid stent deformation and vessel injury. And then we perform the KBT for the second bifurcation. Finally, we'll perform POT for the lemon using a 4O balloon. This is the final angiography after the PCI. We can see the bifurcation lesion is treated well. From the other two projections, we can see the ostium of LAD and OM1 branch is well treated. The final IVAS confirm the expansion and the position of the stent at the lemon and OM1 branch is well, and there is no local complication at the proximal circumference. So we wire 3 vessel and pre-dilate the LAD to protect the LAD, and we first implant one stent, first stent from lemon to the intermediate first, and with a gel balloon for protection. And then we rewire the side branch using assistance of double lumen catheter to prevent wire going outside of the stent. It's very important. Then we perform a gentle KBT to open the stent track like this. And then finally, we put the second stent, and then we wire and perform final kissing using a non-compressed balloon. And finally, we perform POT for the lemon to get the final result. How about the midterm result? 4 years later, this patient received follow-up angiography. You can appreciate the stent remain pattern very well. It looks like the immediate result after the index PCI 4 years ago. From the other two views, we can see the similar result. So in conclusion, we think the PCI for distal lemon traffication is a challenge. No one size fits all strategy is available. For example, if a patient like our lesion, but with much more prey at the proximal circumference, maybe we need a third stent. In another scenario, if the severity of the intermediate is less severe, maybe we just put 2 stents at the LAD and circumference and just open the stent struck toward the intermediate artery. In special condition, we can just use one stent from lemon to LAD and open the stent struck only. And the choice of treatment strategy should be dependent on the discrepancy between vessel size, extent of the calcification, and angle between vessels. And we should familiar with a 1 stent and 2 stent strategy, as well as the way to protection side branch. This is the key to successful PCI. So I think my topic should be Coulomb technique or the double crush technique with assistance of a gel balloon to protect LAD during the treatment of distal lemon trifurcation lesion. Thank you very much for your attention.
Is it possible to do a comment or not?
Yes, question or comment? Okay.
Just one comment. So the rules, we have rules. When you put your first stent, okay, there is the risk of longitudinal stent deformation. So the rule is, soon after you put your stent in the main vessel, the first thing before removing the wire is do the pot. Because in this way you remove as soon as possible the jail wire. But why did you didn't do the pot?
Instead of this, he used the double lumen catheter to enter toward. But yeah, so there is no more risk of going outside the stent. But there is a risk
of longitudinal compression.
Of compression, yeah.
Okay. Yeah, I think there is another message is that because done properly the first procedure at the very beginning, maybe you will not have this problem of trifurcation restenosis, because there was a bifurcation refusal 2 times in the first procedure. So stent at the ostium of the LAD, stent at the ostium of the marginal. So that's why some years later you have restenosis of the left main, of the circ, of the marginal. So very important not to refuse a bifurcation, not to avoid the bifurcation at the very beginning. But what you have done then was perfect.
Other question or comments in the room also? Okay, so it's time to vote. And we'll move to the next speaker.
So Thierry, how frequently are you still using two catheter, 5 and a 6, when you have a real 3 bifurcation, you want to do everything in one shot? Is that still...
The ping pong, you mean?
Yeah.
No, we don't do it.
I don't remember I used that in Massy, never.
No, we don't do it. We move to 7 French, usually when we have a trifurcation. A very big vessel, we may move to 8 French, but the majority of cases it's 7 French. And usually we do a 3-sink balloon inflation at the end with 3 balloons in each branch. In 7 French, you can do it.
You like it very much, but the result is good, but we don't have data on this, of course. So the second speaker will be Dr. Bennett instead of Dr. Jodens. I will present a complex bifurcation in-stent restenosis again. How did I treat?
Yes, good evening. So I got a phone call late last night to present this case, so I will do my best to present it as well as I can, but bear with me. So this is a patient, a 71-year-old male with stable angina. You can see there are quite a few risk factors for cardiovascular disease. There's his medication list as well, and quite a significant medical history. So back in '91, he had a myocardial infarction, and as you can see on the image on the top right there, he had a CABG, lima to the circumflex, and a rema to the distal right coronary artery. In 2017, so quite a number of years later, he presented with again stable angina and had a true bifurcation lesion of the left main, and also a lesion in the diagonal branch. So he had PCI, a culotte technique with a Triton stent, and I'll show you that in a moment, with stenting of the diagonal branch as well. And then in December of last year, he presented with stable angina and had in-stent restenosis of the left main coronary artery, for which he was treated with OCT-guided PCI and drug-eluting ballooning. So if we look back to the 2017 left main procedure, we can see here he had a Synergy stent, a 3.5/24 in the LAD, and further on in the circumflex, he had a Synergy stent as well at, I think, 275. And this was using the Triton bare metal stent to kind of simplify the culotte technique. And here he presented then a number of months after that with severe in-stent restenosis of the LAD, but also more critically, I think you would appreciate, in the proximal ostial circumflex, where I guess the bare metal component of the Triton stent was exposed. OCT is performed here, and you can see severe in-stent restenosis at the mid-CX and also at the ostium circumflex. Probably a degree of underexpansion, but also some neoatherosclerosis and neodental hyperplasia. Here we look at the OCT run coming back from the LAD, and we can appreciate here in the imaging that the stent, Synergy stent, in the more mid-LAD, proximal LAD is quite good. However, at the ostium, there probably is some, which is the top right image here, there is some underexpansion, and again, neoatherosclerosis as I think one of the components for the drug-eluting stent failure. So how was this treated? Basically, first of all, a normal balloon was used in the top left, but you can appreciate here that 2.5 balloon did not open very well. So a cutting balloon was used, a 3.0 at the bottom, after which it was kissing performed with two 3.5 non-compliant balloons, after which, again, with two 3.5 Pantera Lux drilling balloons, kissing was performed in the circ and LAD, and there we have the final result, which looks, I think, angiographically quite nice. Though you might appreciate again at the ostium of the LAD, perhaps some underexpansion are not the most perfect result. Unfortunately, the patient presented 4 months later with again recurrent angina. An MRI was performed after this angiogram, revealing viability in the circumflex region. So of course then this has to be treated as well. Thankfully, the wiring, though I was not present during this case, I was told the wiring was quite easy. So wiring, and after some predilatation, Professor Dens decided to use the ALCA laser to really perform debulking of this, very high grade and diffuse intrastent restenosis. So use a 1.4 millimeter laser. Quite often we use a 0.9 for undilatable or uncrossable lesions, but if it's really a larger vessel, the 1.4 can be used. So laser was performed in the circumflex and also in the LAD vessel. I believe this is the pullback before lasering in the circumflex vessel, just looking at the to try and identify the reason for the stent failure. And again, it's diffuse. I think also some neoatherosclerosis, some neonatal hyperplasia. It's difficult to assess any underexpansion here. So after that, Synergy 3.528 was placed from left main to LAD. POT was performed with a 4.5 balloon, recrossed into the circumflex, and a TAP was performed placing a 2.538 stent from circumflex into the left main. Kissing was performed straight away after this. And then again with a 3.5, two 3.5 non-compliance balloons, this was performed, giving us this result. I believe this is roughly about 6 months ago, and so far the patient is doing very well. Imaging was performed at the end of this procedure just to try and make sure that we had the optimal result possible. And we can see here, I think you can appreciate, hopefully this will move for you, but you can see here pullbacks in the LAD and in the circumflex, showing I think a much better expansion in the proximal LAD, ostial LAD, and also in the ostial circumflex artery. Do note lots of calcium present in the vessels. So I guess this case is a case of severe in-stent restenosis, which of course is a challenging issue. The recurrence rate, for especially when the ostial circumflex is involved, is quite high. And I think imaging, IVUS guided, OCT guided, is really a good way to try and treat these lesions. Of course, there's different options to treat in-stent restenosis: high pressure ballooning, cutting balloons, intravascular lithotripsy, lasers in this case, in-stent rota. Shockwave, I think, is a newer modality that I think had just come into their hands at this stage when this patient was treated. But I think for stent underexpansion due to underlying calcium, shockwave definitely also has a role to play. And of course, CABG is another possibility. Thank you very much for your attention.
Question, remarks? A long time ago with Thierry, we had an experience of rotablation to treat restenosis. Once it was in bare stents and was not working very well. So,
but it was better than balloon.
It was better than balloon. But so now we are doing at that time, we are doing a lot of culotte with bare stents, and we had a 40%, 45% restenosis rate. Was treated by rotablation both sides, and was still high rate of bifurcation. So I just want to, Patrick will say better than me. So it shows us that when the patient has the restenosis, we have also to take into account the treatment which is done and the new restenosis rate. So this is the first restenosis is not the end of the story of the patient, especially for trial. This is an endpoint, but this is not the end of the story of the patient. You have to take care what will be the result of the second treatment for the restenosis, and maybe the third one and the fourth one.
If may I have a question? Congratulations for the case. The question is, what about, could you tell us something more about the strategy with the drug-eluting balloon? Did you use the dimensions of the artery from OCT? Did you try to optimize the results? Did you...
Yes. Sorry. Yeah. Okay. Yeah. Well, from what I've heard or been told, that I think imaging was used in both cases. Also, initially when during the first failure case, and I think the result didn't show a complete optimal result at the ostium of the LAD, but they did use the appropriate sizing, 3.5 non-compliance for kissing, and also for the juggling balloons. So I think size-wise, yes, but perhaps the laser helped to get that some under expansion away in the LAD.
Was a question or remarks, so we can vote?
Yeah, nice presentation. Thank you. My question would be about the possible indication for brachytherapy, because it was in the past, it was possible, and maybe we will face, because of treating very complex patients and lesions, maybe we will face again several types of restenosis, and maybe not the first one, but the second and third one.
Yeah, I mean, I'm still on the younger side here, so I have had no experience myself with brachytherapy. Perhaps somebody else could give some input of that, if it's on the way back or not. I'm not aware of that.
No, I think that today to try to implement a brachytherapy case will be a major challenge. I mean, for those who have done that, yeah. But it's true that in Washington, Ron Waxman has still a very good practice with brachytherapy. You know, these individuals have been 1 stent, 2 stent, the 3rd stent in the same. Yes, brachytherapy will remain a solution for them. And he's doing around a little bit less than 100 patients a year, I think, because it's coming from everywhere in the United States to do the brachytherapy, because the system is working, there is maintenance, and et cetera, et cetera.
Okay, there's, thank you very much for the case. This is the case true lumen sandwiches in Eucarina. Presenter is Gutierrez Kiko. It looks interesting.
It is. Thank you very much, Mr. Chairman. This is a live case performed in a CTO workshop in Valladolid University Hospital. So we were several operators involved in the case. So it's a 54-year-old male patient with angina and with ischemia demonstrated in the scintigraphy, has a normal ejection fraction and no wall motion abnormalities, so the viability of the anterior wall can be assumed in this case. So the indication of revascularization was clear. As you can see in the angiography, I don't know why the other, I don't know why it is not working. Maybe I can get some assistance to show that it's an ambiguous cap of the proximal LED. We checked in the computer and it was working fine. Yeah. Might someone click on the second video? Well, okay, believe me, it was an ambiguous cap. You will see it in further loops. Sorry for this inconvenience. So we decided to perform a retrograde approach because the interventional collaterals were good, as you can see, very easy cross. And the plan was doing an IVUS-guided re-entrance, direct wiring from retrograde. You can see the wire in the circumflex. But when we were trying to cross with an ultimate wire, it crossed very smoothly into the left main and directly up to the guiding catheter. So there was no chance to do that. It's really a pity that the videos are not working. They will ruin the whole presentation. Sure. No, we decided to perform directly a retrograde case because it was an ambiguous cap and there was a retry to do it antegradely. So we decided to go directly retrograde because we thought it would be easier. So in the left main, we always check with IVUS how it is, and this is, pay attention because this is the key image for the story. We are in the circumflex, you see the wire at 3 o'clock, more or less. You see a subintimal course right now, but when we are still in the polygon of confluence of the bifurcation, the wire has re-entered. And in the left main, it is in the true lumen, and there is no distortion of the vessel architecture. So, deciding on this, we decided to externalize the microcatheter to exchange it for the RG3 wire and to do predilation with a balloon. This is going to be a nightmare. I think I have discovered what is happening. It is not activated the the loop continuously. Well, too late. So, if I may ask to the audience, which of you, after seeing this angio that you have not seen, sorry, it's they have killed the whole case. How many of you would adjust the stent to the LED ostium? How many of you would stent across the left main LED? If anybody could click just on the video, just to let the audience express their opinion about the strategy. It's going to be, yeah. Well, maybe I can describe how it was. Well, we did the first antegrade injection.
So, if you stand across the circumflex, the wire was outside the lumen in the LED.
I think it's not the repetition activated. It was in my presentation, or let's see.
I think if you do that, you will close you will close the LED.
No, I mean stenting left main LED. LED.
So you see that the wire didn't re-enter correctly because the two wires usually you integrate and you encounter the two wires already outside the bifurcation.
Well, the wire re-entered. This is what we saw in the IVUS.
So by IVUS you saw that there was you have a subintimal entrance in some part in the left main, but not. It was past the ostium of the circ.
Exactly.
Okay.
So it re-enters in the polygon of confluence.
Exactly. So. So if you stand, then you close the circ. This is not completely, but at least.
I mean, maybe he's attempted not to recross, but to use two stand a la gun. You know, you remember that? Gun was putting two stand, a barrel technique in the main stem, which has not very good long-term result, but. At a certain point, S.J. Park was doing that, and we all have seen that famous IVUS pictures when you see intimal hyperplasia on both sides of the metal. There is indeed the two stent in the main stem. That's maybe the temptation of Chico, no?
So now we saw finally the angio. May I poll the audience? How many of you would try to adjust the stent to the LED, and how many of you would stent across the left main LED? A. Please raise your hand. And how many would stand across the left main? Okay. So the operators decided to do A. That was the temptation. And when we were doing that, you see, we did it with no problem. And when we did that, the wire in the circumflex was entangled with the balloon. The people were enthusiastic. It was a live course, cheering for the easy result. And the wire was easy, was difficult to replace. So we decided not to replace the wire because we deemed the situation of low risk. So this is what we found when we did the first injection.
Can I stop you? Why did you did not pull any balloon in the left main circuit and inflate the balloon just to be sure that you didn't protect the circ with the balloon?
No, with the balloon we didn't.
Yeah, because in this case, to avoid to put a balloon, inflate the balloon, and then push just to be sure that you don't slip the stent.
Yeah, but after that, if you inflate in the left main to circ, you will close the LED.
Yeah.
No, because there is a stent. But you have already a wire in the circ, so you are safe. Even if you close the circ, you can just put a small balloon and open the circ. So then you have to think about what will be the next strategy. But it's not so simple. The other problem is that the size of the stent is a little bit maybe too big, so that's why you completely push the carina and close the circ.
Yeah, that's what we are going to explain now. Sorry for all the technical inconveniences. We sized the stent according
look
to
at the image
IVUS.
on the right now. The circ is closed because he's overlapping and he's probably in a double lumen in the LED, which is a kind of dissection which is ending at the midway.
Exactly, exactly.
That's interesting.
So we ballooned the ostium of the circumflex 3 times, no result. This was the result, so we decided to perform an IVUS and to understand. And if you can see here, we are in the circumflex. We rewire with no problem the circumflex. And here you see the image, you see the LAD, the wire, and notice the image that explains what has happened. It is there. Now we are going to mark it. This is the image. And when we saw this, then we understood the mechanism, which is what you were anticipating. We didn't elaborate on the IVUS so much. So what has happened is that when we went retrograde, our wire had a small subintimal course close to the carina. When we deployed the stent, we didn't cover the entry point. I think that's the key of the story. And when we deployed the stent, we extended the subintimal space. That's why when we try to balloon, it's elastic. We balloon with no problem, but it recoils and the circumflex remains closed. So after having understood what had happened, we checked this time from the LAD. We did an OCT and noticed the true lumen smashed against the vessel wall in a small traject, and that double lumen that professor was anticipating very nicely. This is explained. This is the stent. Very close to the carina, you see the true lumen smashed against the vessel wall. Here you see the flow divider, and here you can see the entry point that had not been covered by the stent. And here is the wire entering through the true lumen in the circumflex. So the left main remain as well. In the longitudinal view, you see it clearly, the expansion of the subintimal space and the wire connecting the true lumen to the circumflex. This is the 3D. Fancy,
you know, Chico, what is really impressive here is that you have to be a Sherlock Holmes if you want to understand the pictures on IVUS, where everybody can understand the pictures on OCT. That's very clear.
Yeah. This was the remark that guy sitting there did and convinced us to do the OCT just to document it very nicely. 3D is nice, but in this case it's useless to understand that. So we started restoring the flow at the circumflex, stenting it, no problem. And then we checked again with IVUS, this time from the LAD. You can see the neocarina, and you can see that there is a persistence of an intimomedial flap still in the proximal part, in the left main. So we decided to stent the, to stent the left main and closing the entry point. This is the final OCT that we obtained here. And as you can see here, if we explain that, now you can see this true lumen or neointimal flap sandwich in the neocarina. In this first slide down, you can see it more clearly. And then in the middle, we see what we called in the cath lab a piniform prolapse that we have presented here, more politically correct, as squib-shaped prolapse, which corresponds to that intimomedial flap leading to the true lumen. And that is the case. So the take-home messages, any subintimal course around the carina must trigger our attention because it can lead to complications. The importance of imaging to solve complications because it allows you to understand the mechanism underneath and to tackle the problem appropriately. Maybe we could call what has happened here subintimal shift, because here in the Bifurcation Club we started talking about plaque shift, then we started to talk about carina shift, and this, in this specific scenario of CTO bifurcation, might be we could talk about subintimal shift in this end. And finally, the importance of stenting the entry and exit points whenever you have a subintimal course in a CTO. Thank you very much for your attention.
So, Chico, the squib, like you call it, yeah? It's a kind of plicature of the re-entry. That's what we see there?
Yeah, I think the interpretation, I'm trying to go back, is if you think of the subintima, of the true lumen squeezed against the vessel wall, this is the continuation up to the neocarina. Yeah. And then, I mean, if you see the three ones, the left one is the most distal one, and the right one is the most proximal one. It's like the intimomedial flap bending and leading to the squeezed true lumen.
Yeah.
Yeah. Thank you.
The last comment. The CTO guys, they analyze the CTO and bifurcation. And there is a rule that when you have a bifurcation and you want to re-enter retrogradely, just to make the connection, not at the bifurcation, but away from the bifurcation. So they start usually, even if it's retrograde, they start antegrade, they go subintimal, subintimal at the ostium. So go inside, they try. If they are sure to be subintimal, but in proximal LED, they stay, go retrograde, and then they put an extension catheter and they recapture the inside the LED an extension catheter. So they are sure that they are not involved in. So this is the tip to learn from this.
Yeah, that's a very good remark.
Go antegrade, dissect, but not the circ, extension guiding, and re-enter in the.
No, if you look our steps now retrospectively, we were overconfident. The point is we have planned to do an IVUS guided direct wiring, just to avoid that. Maybe if you are doing an IVUS guided real time, you can check that you are going intraluminal, that you don't have a subintimal. But when we tried with the ultimate, when we were preparing the IVUS, it went smooth up to the guiding catheter. So we said, okay, maybe the likelihood of going subintimal is very low. We are live, we are easy, okay. And then we were confident and we moved ahead. When we checked with the IVUS, we said, well, it's a small subintimal course, but it's close to the carina. Never mind, let's dilate. And the dilation, the first antegrade injection was encouraging, even though here everybody has voted a different thing. But there in the lab, all the experienced operators, they agreed to try to adjust the stent to the ostium of the LED. Mistake. Overconfident again. Then happened what you have seen and you anticipated.
Yeah. So this illustrates again the fact that if we refuse to treat the bifurcation, we are in problem. Because if you have done the stent from left main to LED according to the correct size, because it was a little bit too large for the LED, you will not have this kind of problem. So always do not refuse to treat the bifurcation. When you have a bifurcation, it's a bifurcation. Follow the rules, even in CTOs.
Absolutely.
Very good.
Yeah, we have a comment.
One question, yeah.
The joining point should be far away from the bifurcation. And if you stand from left main to main branch and you have this kind of subintimal space, you have the same problem on the circ. You are not sure that you are safe doing stenting from left main to LED for the circ if you have this subintimal space. Of course, maybe a little less, but the solution is to go far away with guideliners. So that's the point.
I have to do last comment to finish. The imaging was spectacular, so it's really astonishing.
Thank you very much. Thank you.
Very good. So apparently we go from the sandwich to the double debulking for left main true bifurcation lesion by Kinoshita.
Good evening, ladies and gentlemen. My talk is also about true bifurcation region. So, but I'm not sure if you can imagine my strategy from my title. But in some part, you may think that it is too much. So, but at that time, please close your eyes for a while. Okay. This is my disclosure slide. And let me introduce my case. My case is a 70s male with gastric cancer. He needed open abdominal surgery as soon as possible, but as you know, the surgeon refused under this condition. So we have to we decide to treat this patient. So as you can see, this patient, the LMT disease is a very, very calcified through bifurcation region. And this IVAS is from the already distal to the left main. As you can see, this is the circumflex. So this distal left main, as you can see, the calcium layers sandwiched the region, and then this is the bifurcation region. As you can see, we can see the severe calcified Chirac plaque, both vessel, and this is the circumflex, osteomal circumflex. Osteomal circumflex, fortunately, we can keep some diameter, but we can see we could see the calcium layer about the opposite side, at the opposite side of the carina. And just one minute. Yeah, and then this is the left proximal LED. As you can see, proximal LED also calcium layer and some fibrous plaque. So in this region, how we treat. First, I use rotablator to the left main to LED and the left main to circumflex. We choose the 1.75 bar, and the middle panel and the right panel is a post-atherectomy with a 1.75 bar after into the left main to the LED. And then we used 2.5. We escalated the bar side up to the 2.15. And the middle panel and the right panel is a post-atherectomy with a 2.15. And then using the same bar, we operated the just ostium of the circumflex like this. And this is the angiogram after the rotablation with a 2.15 into the both branch. So as you can see, the circumflex is quite good, but left main to the LED, you can see the some stenosis remained. So after that, what we should do? Our choice is this is I was the image from the left main to the LED from the after the rotablation. Here we can see some fibrous plaque on the calcium layer. So from this IVAS, we decided to in this region. We decided to use directional coronary atherectomy device in this region. So maybe until 15 to 20 years ago, the DCA was available in all over the world. But unfortunately, now this device is available only in Japan. So this device, in comparison with the old one, this device become more powerful. Motor drive unit speed of the rotation of the motor drive unit is about 2 times in comparison with the old one, and also material of the cutter is very hard. So by using this device, we try to debug some fibrous plaque and some calcium plaque. Sorry, again, could you click the both image? Yes. So opposite side of the circumflex, I try to debug several times, and just a moment. Just a moment. Okay. This is the IVAS after the this is IVAS image after the directional atherectomy. So please repeat again. Sorry, could you click it again on the right panel? Yes. Yes. So in comparison with the pre-DCA here, so we could remove some fibrous plaque and calcium plaque. And this is the final result. So after this treatment, this patient could take the surgery after the 2 weeks later. And okay, this is a 6 months later follow-up angiogram. As you can see, a little bit progression of the left main, but that is not so big issue.
Just above the catheter there is a kind of line of contrast there. Not a little bit worried about that?
Yeah. Sorry, that is not so good. So angiogram. Maybe my young fellow did that. I'm sorry.
Did you do some additional treatment, or that was the final stage?
Yeah, I don't know. I didn't. Yeah. Then this is sorry, and this is 2 years later. On the left main, stain of the left main is the calcium shadow. So we can keep the good result after the 2 years later. So of course, this patient is still fine. And so as you know, so there is some report about the risk of the short duct in the patient with complex PCI. So actually, recently so we have to keep the duct after the stenting at least 3 months to 6 months. But especially it is difficult to stop the duct within 1 month for the patient who had the stent in the left main bifurcation region. But it is a fact that there is some patient who cannot enough duct because of their lying condition. So in such a patient, I think that such kind of crazy, not crazy, aggressive debulking without stenting strategy is sometimes so useful for the patient, and sometimes bring a favorable result for the patient, I think. And we always mentally prepare for the stentless treatment for the patient. Thank you for your attention.
I have only one comment. Your last sentence, the bulking result occasionally. Occasionally, this was
occasionally.
Occasionally was the key. Is the case that.
So you have
you recognize it was a case.
You have a large experience of DCA in Japan since many years, and you are the only country continuing to use it. So it means that you are really experts in this field. What are you doing about DAPT? So you don't you are not given DAPT after DCA, or for how much time?
This patient. Yeah.
In general, when you use DCA, how much time you give DAPT?
DCB?
When you use directional atherectomy, Simpson, how much time you give DAPT?
Plavix and aspirin.
Orbit.
How long treatment for DAPT for this case?
How long? Sorry.
You gave for 1 month clopidogrel and aspirin.
In this case,
yes.
In this case, actually, there are only 1 week.
1 week.
Because as I said, 2 weeks later, this patient had abdominal surgery. So only 1 week. Only 1 week.
So after
then there was atherectomy only with aspirin. You forgot that it's with the stent that we went to the DAPT, but after atherectomy we were giving aspirin.
Yes, but when we move from aspirin to clopidogrel, we decrease the rate of acute closure within 24 hours. So that's why we use clopidogrel at that time for stent. We start to use it for stent because of experience with balloon.
Yeah.
Okay.
So thank you very much for
thank you.
Go on. So we now have a case of extreme left main stem calcification, the rota shock combination. That okay?
Thanks for the invitation for choosing this case for this award ceremony. It's a great distinguished panel. Everything we do in the UK is extreme. That's why we've got this Brexit saga, but that's my only mention on Brexit. So this was a case that I performed in May, the day after coming back from PCR. This is the clinical presentation. It's a 79-year-old patient who comes in to our lab with unstable angina, transferred from our sister hospital. She's been having breathlessness for several months preceding her admission. The echo shows ejection fraction of about 45%, with some akinetic wall motion abnormality at the apex. Otherwise, it's pretty good. That's the ECG. And you'll see with her left, well, before we did the left shots, you can see there's quite a lot of calcification just on the static angiogram for the left system. And if this one plays. So here's the angiogram of the left system, as you can see. So we've got a Medina 1 classification, bifurcation left main, calcification, as you can see. There's a small intermediate as well. And a fair, so I looked at this case and thought, right, we're not going to carry on. We're going to stop and take her off the table and discuss options. So we take her off the table to discuss the options of PCI versus CABG. I mean, we try and avoid CABG in this age group, but sometimes you have to for this type of case. But having discussed with her and her family, she was really adamant she didn't want CABG. So we decided to go ahead with PCI, offered her about a 3 to 5% risk of complications, mainly based on the calcification and, of course, some impairment of LV function. So brought her back to the cath lab, upgraded the sheath to a 7 French, give us more options. And my intention was probably to rotablate, but I wanted to see how a balloon would travel, and a low-profile balloon wouldn't even cross into the LAD. So that confirmed I needed to debulk with rota. And I planned a 2-stent technique in this procedure with a culotte or DK crush. That was my plan up front, and I was going to IVUS this case to get adequate preparation and so forth. So I used the Caravelle to deliver the rotor wire, fairly straightforward, and took a 1.5 burr, understanding it's a little bit small for the left main, but given the fact it was difficult to cross, I thought we'd start small, perhaps work up. So gently going through with the 1.5, and then polishing with the 1.5, and then took the opportunity to get IVUS with Eagle Eye. So this is what we sort of found schematically, and we use Sync Vision IVUS, which is quite helpful because you can really map out where you are and co-register it. So we had quite a severe lesion at the ostium of the LAD, as expected, with calcification in a sort of concentric array, but the more proximal left main wasn't too bad. So it was all down at the distal end. So this level of calcification, I think I could see one fracture there, we just see on that kind of moving frame. So rotor had done some modification. And I guess the question is now what to do. When we're dealing with these type of lesions, we have options. I don't think I'd go back with a balloon at this point. This is not playing. Here we go. So we have options. We can use scoring balloons, cutting balloons. We could upsize to a 2.0 burr. I don't think laser is very helpful here, but obviously shockwave is another option. And we've had shockwave for about 10 months in our centre. We've done about 45 cases. And it really is quite good disruptive technology. But I think before, not only is the imaging fairly convincing, but the balloon took a 3.5/15 balloon, just a modest pressure 1-to-1 sizing, and you can see it clearly didn't expand. So it's interesting when we put this out to poll. Tom put this out on Twitter, which is the new way of discussing cases now in cardiology, and 113, I think, people voted. And the consensus was that actually 50% would go for IVL, others would upsize to a 2.0 burr. So that's an interesting concept. Here we go. Sorry, it's a bit slow, but this connector. So this is the IVL balloon, 3.5/12. I use a 1-to-1 sizing. I think that's the recommendation. It uses unfocused lithotripsy, unfocused sound waves, basically, to give you a sort of 50 atmosphere type dilatation. And we delivered 40 pulses pretty much at one point, using the sync vision to really localize where the most calcium was. And once we'd done that, we were then able to take an NC balloon, and you can see we've got pretty good expansion. I think the LED is now well treated post-rotor shock. So I put a distal stent in because we'd prepared that and we'd done some rotor down that. So that's the distal stent covered on IVUS, just showing that it's all well expanded. And then turning attention to the circumflex, once again a balloon wouldn't cross. So I took out the LED wire and I put the rotor wire down the circ and used a 1.5 burr there, same 1.5 burr. And the ultrasound after that demonstrates fairly, as you'd expect, a lot of calcium again, which is concentric, lots of bulky material. Once again, I didn't feel that I was likely to get good resolution just with balloons at this point, particularly if I was going to do a 2-stent strategy. So I could upsize to the 2.0 burr, but we had 40 pulses left with our shockwave balloon. So I could take that back, deliver that. Even though it was winged, it went quite easily after rotor. And that's the beginning with the sort of the first pulse. You can see slightly underexpanded, and then when we take the 40 pulses that we had left, we get better expansion. So really quite impressive lesion preparation. This device is really useful. So once I'd done that, then I put a Xion stent more distal in the circumflex. And now to the bifurcation itself. How are we going to deal with the bifurcation? Well, I guess we've got two options. We could go with DK crush. This is just some bench thing modeling we did ourselves, but which would have been a very reasonable result. But the benefit for me in DK crush is if I didn't want to lose my main vessel wire, I've already taken that back. So for me, I was going to do a culotte. I had pretty much 1-to-1 sizing, no differential sizing between circumflex and LAD. You all know how to do a culotte, so I don't have to run through that. The pot, I think, is really important. But this is what Twitter said. So Tom put this out on Twitter, and really quite interesting results in that 75% of people would have gone for a DK crush, which I think is a bit different perhaps to a few years ago. So once again, tools in the cath lab are so important, and with our new radiation, ionized radiation technology, we're able to do things like clear stent. You can really see exactly where you're positioning the stent. So having put in a 3.5/28, then the next step for me is always pot, as I've learned from this meeting over the last 10 years. Making sure we've got good expansion in the left main stem. And then actually, in this case, I decided to use a dual lumen catheter. No massive reason, you could have done it without, but it just means I can 100% make sure that I'm not going to go abluminal behind the stent. So wire the LAD, and then open up the struts, and then again using the clear stent just to put in a 4.023 Xience into the left main. And again doing pot with the 5.0 balloon. And then we're in a position then to do our final kissing balloon after rewiring the circumflex, again performing IVUS. And we can quite nicely see that we've got pretty good result across the ostium, the left main getting up to 9.7 millimeters squared, and the left main itself up to 13.9, which is pretty much in keeping with what we're trying to aim for in terms of our left main final MLA or CSA. So that's our final angiographic result. And I must say, having used this combination of rotor and shock in a few cases now, I'm quite impressed, and I think I get better results than if I'd upsized, has done in the past with 2.0 burr and just stuck to rotor. So in summary for this case, it was a calcified Medina 111 left main bifurcation. It was uncrossable LAD and circumflex, so we used rotor to cross and also debulk the lesion. Then we used intracoronary imaging to really help understand what was going on and guide the intervention. We had options then for atherectomy about whether to upside or use more rotor, perhaps laser, but actually I think intravascular lithoplasty is probably the best way forward, as in this case. And then we chose a bifurcation strategy with culotte. And we ended up using 4 wires, 14 balloons, 4 stents. So it's quite an expensive case, I guess, but at least I reused the single IVL balloon and the single rotor, and we didn't use too much contrast. Thank you very much.
questions or remarks? Goran? Thierry? Question in the room?
The perfect case.
So, okay, thank you very
Thanks,
much,
guys.
Peter.
I got off very lightly.
The last case.
Last case is going to be presented by Dr. Singh. It's another left main trifurcation treated with two different stent techniques.
Respected chairpersons, panelists, my dear colleagues, ladies and gentlemen, good evening to all of you. I am Parminder Singh. I am working as faculty in the Department of Cardiology in Postgraduate Institute of Medical Education and Research in Chandigarh, India. My case is unprotected left main trifurcation lesion treated as two sequential bifurcations using two different stent techniques. I am sorry for my bad throat, please bear with me. I have no financial disclosures to declare. So the case objective is to discuss and learn the management of left main trifurcation lesion, especially in patients with acute coronary syndrome, and if at all we decide to go for multiple stent strategy, how to simplify a multiple stent strategy in such patients. My case is a 27-year-old male. Of course, it's a premature CAD, who is a cab driver by occupation. His clinical history includes recent onset angina class 3 for last 25 days with one episode of rest angina and dyspnea on exertion again for 25 days. So patient is basically symptomatic for last 25 days with one episode of rest angina. He has risk factors of hypertension for last, he's hypertensive for last 2 years and has family history of CAD with his parents having coronary artery disease, although it was not premature CAD. His diagnostic tests include ECG, which revealed ST depression in V3 to V6 to the tune of approximately 2 millimeters, and echocardiography was normal, LV function was normal, and troponins were positive, elevated. With this clinical presentation, he was diagnosed as non-ST elevation MI acute coronary syndrome. We did the angiogram, which showed distal left main is minimal plaquing or almost normal, and there is a trifurcation lesion in the distal left main with involvement of ostial LAD and ostial LCX, and there is a critical lesion in the ramus, which is bifurcating and looks sizable and larger branch. RCA was normal. Distal LAD is again normal. So with these angiographic findings, he has got trifurcation lesion in the distal left main with the ostial involvement of all these three vessels, modified Medina 0111 for a trifurcation. And ramus again has a bifurcation lesion distally, and one of the branches is deceased, other branch appears to be normal starting from the ostium. RCA is normal, and possibly the patient is symptomatic because of the ramus lesion, because this is the most critical lesion in his angiogram. His syntax score was 18, and there is an equivalence for CABG versus PCI. We discussed both the options because we may have to go for multiple stent strategy. Although patient refused CABG and was opting for PCI only. So what strategy should we go for left main trifurcation in this patient? We have multiple options, like we can go for single stent, 2 stent, or 3 stent strategy. In deciding the strategy, I think bifurcating a ramus is important vessel, which is supplying a large area of the myocardium. Personally speaking, I would prefer a 2 stent strategy, but at the same time, I will have a lower threshold for ramus stenting. And if at all I plan to go for 3 stent strategy, there are 2 options: either do trifurcation stenting or I go for 2 sequential bifurcations. Trifurcation is a little bit more complex, needs 8F guide and technically more demanding. If I manage it as 2 sequential bifurcations, it's relatively simple and needs a 7 French guide. So how I treated this patient? My strategy was to use 2 stents, one in the LAD, one in the LCX, plus minus 3rd stent, which is to be decided on the table. Technique for the LAD and LCX was V stenting because both the vessels were of similar size and left main was relatively free of disease. If at all I plan to decide to stent the ramus, we have multiple options, and there is a wide angle between the LCX and ramus. IVAS was not done pre-procedure because patient was having intermittent chest pain and is diagnosed as acute coronary syndrome, and I had the risk of losing ramus. So EBU guide was taken, and all these three wires, all these three vessels were wired. In the ramus particularly, we went to the branch which was more diseased, and there is a long disease in the ramus. Then this lesion was dilated with 2.5 20 millimeter balloon, and LCX, there was a balloon which was kept in the LCX just to protect it. And again, I mean, it was pre-dilated also later on. Now, after this, in view of, after opening the ramus lesion, we found that it's a very large vessel which has two branches. Again, it has two bifurcations, and we decided to stent it at that point of time. So a 2.75 24 millimeter stent was taken, and it was inflated by keeping some of the studs protruding into the LCX, keeping a balloon in the LCX. After this, it was post-dilated with non-compliant balloon, 2.759 millimeters at 14 atmospheres. And this was followed by inflation in the, of the balloon in the LCX also to protect it, and pre-dilated. At this point of time, patient started having chest pain. Actually, I didn't have seen at the moment, but his LAD lesion was actually closing, possibly maybe due to spasm or plaque shift. And we pre-dilated LAD lesion with 2.5 millimeter into 15 millimeter semi-compliant balloon. After this, we took two stents, 3.5 millimeter each, and decided to stent that both the osteal lesions and in a V fashion. Both these lesions were dilated at 14 atmospheres, and this is what we achieved after stenting both of these major vessels. At this point, we see that we have removed the ramus wire. Ramus was rewired, and kissing balloon dilatation was done at 16 atmospheres for LCX ramus bifurcation. And this was followed by kissing balloon dilatation of LAD and LCX bifurcation. And this is the result that we achieved. After this, IVAS was done, and in all the three vessels. And what it revealed was that LAD and ramus stents were well opposed throughout the length, starting from the left main, starting from the ostium of the LAD. Although LCX lesion shows some malapposition in the proximal segment, and we had to do a kissing balloon again in both the vessels. This time, balloon in the LCX was 4 millimeters. And post dilatation, we did IVAS, which shows good apposition of LCX. This is the end result. We achieved a good angiographic result. So using this technique, we have two sequential bifurcations, and we have used 3 stents. We keep it in mind that there are certain problems and certain benefits also. We have good patency of all 3 vessels at the end of the procedure. We have finished the procedure with 7 French guide. And multiple layers of these stents we prevented because into the left main, because we have kept the minimal protrusion of the ramus stent into the left main, into the LCX, and there is a short length of the carina. Although there are certain concerns of restenosis and stent thrombosis in this particular patient. So what I feel is distal left main trifurcation is a complex lesion. Optimal strategy is not well defined. Basic rules of bifurcation lesions apply to all these patients, and we should try to keep it simple. But if at all it's required, I think we can go for 3-stent strategy. Also, this is not a planned strategy in all the patients that we should try to reduce the number of stents. But if at all required, I think we can go for that and achieve good results. This lesion can be, this kind of lesions can be simplified by using 2 sequential bifurcations if a 3-stent strategy is planned. And this can be done safely and quickly, particularly in patients with acute coronary syndrome. And as in other all left main lesions, intravascular ultrasound is quite helpful. Thank you.
Questions, comments? If not, vote.
And Ben, can you please finally bring us the list? Yes, yes.
We vote, we vote.
Can I just make one comment just before the voting? I think when placing these osteal stents, it's really important to know the distance between the marker and the stent for the different manufacturers. That's really key, because it's the difference between a really good result and a not so good one is missing by 1 millimeter or 2. So just sort of be aware of those numbers for the 4 or 5 different stents that you're all using.
Yeah, that's why we always try not to stent the ostium, but we prefer to stent left main and LAD or left main or circ, because it's so much difficult to put the stent at the ostium that this is what I call bifurcation refusal. So you try not to treat the bifurcation, but at the end, the follow-up will not be optimal in many patients.
So Ben, how long it is? So I think we have seen quite good cases, huh? Complex enough. So we have to congratulate also the selection committee.
Absolutely.
Among them Remo, Olivier, Francesco also was involved, and Maciej Lesiak also was involved. Thank you very much for this work. You reviewed how many cases? 50? Around 50 cases, huh?
There were more cases because some people submitted up to 7 cases. So it was really hard work done in a couple of weeks only.
Yeah.
And the reason why we made this session is to promote case submissions throughout the year. So we would like to invite you to submit cases throughout the year. You will get information and access to website, and we have committee for reviewing. Olivier Darmon, who unfortunately cannot come this year, is the chair of the committee and co-chaired by Remo. So 2 of them are actually moderating all the work, evaluating the cases, grading the cases. We have even broader group of people reviewing some of the cases. And we really would like to have cups like in the Champions League. And case session is really one of unique characteristics of EBC. So instead of just sending cases 2 weeks before the meeting, please submit throughout the year. And we will work more, and we need your advice how to structure even better this one. But really, the whole year activity should be part of the future work of EBC. And we also have a Bifurcation website. We would like you to go and discuss also throughout the year on that website. And we asked Tom Johnson to be responsible for correcting all the work that is done and structuring better social networking system in the next year. So if you have anything to share, please use Bifurcation Club or copy. Everyone should retweet something that comes as a good message. For example, as a test, with the help of Tom, we put on the Twitter case with DCA and drug-eluting balloon. In less than 24 hours, 10,350 people saw the image. I mean, it's really power that we have to use in order to move forward. And please, when you retweet, use Bifurcation Club, and that one will help everybody to be in the loop.
I have to add some. We put the slides in PDF on the website. So if you have to do some presentation during the year, you go to the website, you download your presentation, and then you cite that this case was presented by the author of the presentation. So you know, it's a good thing for the presenter, that will be known. If there is a new technique, it will be recognized that he was the first presenter of that technique, but sometimes he presents the technique and someone else is the author, the false author of the technique. So just to give the the privilege to be cited as right.
Okay, the moment of truth has come. So the third place with grade of 5.8 points was by Dr. Chen, and I would like to invite Thierry Lefèvre to present the cup for the third best case of EBC in 2019. Yeah.
Okay, thank you very
much. Please stay on the stage for the because we want to make a photo at the end. Yeah. For the second place with 7.3 points is Dr. Peter O'Kane, and I would like to invite Yves Loire to present the second best case of the year. And officially the best EBC case of the year 2019, and award will be presented by Professor Patrick Serruius, is for his former fellow Gutierrez Chico. Please come.
So believe me, does it work? It works here. Yes. Believe me, there is no conflict of interest here. No exertion of influence, but I immediately, spontaneously, I said that these images of OCT were remarkable. And you know, when you have left the field for a few years, we have done difficult things in the past, but I'm really impressed by the ingenuity, and particularly in this case, I mean, how really the whole case became clear when you got these crystal clear pictures of OCT. So congratulations, and I think it's a very good, I'm proud to be on stage with you. That's number one, because I train him after all, yeah. And I think it's a very good decision of the club to have this competition, because that's really where the flair of the clinician and practitioner can be demonstrated to their colleagues and peers. And I can tell in my whole life, when I had see a case with a special solution, you never forget. And suddenly in the lab, you are the first to say, oh, I know what we are going to do, because you have seen it and heard about it. That's the great value. Thank you very much, everybody.
And we have gifts for the other three participants, finalists. So, come. You will do, no, please bring here, and I ask Remo to give those three gifts to other three.
There's a gift for everybody.
Yeah.
Not you.
Please come to the stage. Yeah, you give it.
Very nice.
Very nice one, yes. It's
I'll give it to you then.
So Tom, please make a photo tweet of the year 2019. For the tweet, of course. And I wish to everybody in this room to be here next year in 2020 as the winner. Okay, so thank you very much. This will be almost all for today. We invite you to the Jupiter room for a cocktail and some music.
8 in the morning tomorrow.
Tomorrow morning we start 8 in the morning. Please be on time here to start 8:00. Thanks. Enjoy the rest of the evening. We are sorry we cannot go to downtown, but this year is very special from that perspective.